Let me introduce our team and cases. 슬라이드 띄워주세요. 방송 우리 비춰주세요.
Actually, I know in COVID pandemic state, video live demo, you will transmit live demonstration from SNU. This is, I think, unusual.
Thank you, Professor Sang-Hoon Lee. Yeah, I recommend other directors to do a live demonstration rather than video demo, but they didn't agree with me. Thus, I'm the only one who do a live demonstration in the midst of pandemic of coronavirus. But actually, the guideline is down to the 2.0. Thus, you were able to do a live demonstration. My first case of live demo is TAVI using lotus valve. Slide, please. I introduced my team, Dr. Kang Ji-hoon and Dr. Yang Han-mo, the original member of TAVI. Now he is old. He tried to retire, but I always encourage him, urge him to participate TAVI team because he had a very vast experience. Then many fellow Yak-seung and specialist Kim Tae-won from Boston Scientific and Kim Dong-guk, what's your name? Lee Dong-jun, okay. Okay, let's start the slide. 슬라이드 비춰주세요. 박경태 선생이 셀렉션 해야 되나? 지금 좌장만 비추고 있거든. 빨리 하세요. 청중들이 실망하겠어요.
Dr. Kim, we can see the slides here.
Okay. 85 years old male. He has suffered from aggravation of exertion dyspnea functional class 2 since a year ago, and severe AS was confirmed by follow-up echo. 85 years old and BMI 27. He has various kinds of comorbid condition: diabetes, hypertension, previous history of MI, hyperlipidemia, CRF, GFR 34 plus. There's many kinds of medications. Today's target is severe AS treated with TAVI valve using Lotus Edge system. As the score 3.4, intermediate surgical risk, chest X-ray, unremarkable, ECG, just poor progression, conduction was good, plus. Echo, ejection fraction good, 64%. Mean gradient is about 40 tall. Area is 0.9 square centimeters. Plus. Abdominal aorta, iliac artery. There is some calcification around aortic arch, but it's not heavy. Best projection angle would be RA5, caudal 15. The angle is good for implantation. Valve calcification is not so heavy, just concentrated on NCC. We can see the spot calcification at annulus level between NC and LC. That may be a reason for mild regurgitation after TAVI implantation. But good thing is those calcification did not extend down to LVOT. Diameter is about 22 plus. Sinus valsalva is wide, 28, 30, 31. SD junction is wide, also 27. No significant calcification. SD junction height is also more than 19. as the junction profile is very important to consider in sapien valve implantation because proximal frame may touch ST junction causing aortic tear. Thus, I always emphasize the focus on ST junction height, size, and calcification. Coronary height is tall enough, more than 15 plus. Iliofemoral artery, right side is about 6'2", 7'2", 7'7", except puncture site, the iliofemoral artery is wide enough to accommodate lotus sheath system, plus. Left is also good, plus. To summarize measurement, perimeter is 72, area 400. As the junction is a little bit bigger than annulus, alveoli is very similar to annulus. Height of coronary artery and ST junction good. Sinus valsalva, ST junction wide enough. Ascending aorta size is good. Plus, when we consider sapien 3, area is 400. That corresponds to 23 millimeter valve with 2.2% oversizing with nominal inflation. Thus, in this case, 1.56 overinflation would be good to meet 11% oversizing. Plus, when you consider Avalot Pro, 71 millimeter perimeter corresponds to Avalot Pro 26 with 15% oversizing. That is also good. Plus, when we do Lotus Edge, 23 would be possible, ranging 3 to 5% oversizing. Thus, in this case, we can choose any valve among 3 kinds. Plus, I prepared 3 issues. The first, which valve should be selected for a given patient. The other is major issues in TAVI minus pacemaker implantation and leakage. Plus, when you meet our BBB or future coronary access, you have to choose sapien. When you consider area or valve-in-valve procedure, Avalot. When you meet high probability of leakage in patients with heavy calcification or bicuspid valve, Lotus would be best. But the limitation is peripheral artery should be more than 6.5 millimeter. Oversizing index is very important to meet leakage as well as conduction block. In my experience, 10% for sapien, 20% Avalot, and 0 to 5% in Lotus. Plus, in this case, I chose next generation Lotus Edge valve system because SNUH is the only hospital to do this system. So I prepared this case to convey the knowledge of implantation of this system. Depth guard is unique. Adaptive seal is very powerful to obliterate the leakage. Early valve function is very important virtue for this system because during procedure, we can enjoy stable hemodynamics. Plus, to summarize, conventional Lotus versus Lotus Edge system, adaptive seal, nitinol frame, early valve function, size metrics did not change. The only change was depth guard, technology, and one view locking is possible. Delivery system is improved, and sheaths will be improved next year from 18 French internal diameter to 15 French. Plus, the second issue is pacemaker implantation. That is really one limitation in Lotus. Because in global experience, the PPM implantation rate is about 30% or 35%, now about 25%. Experience of SNUH is 16%. 7 ppm implantation among 43 patients. In conventional Lotus, that was about 8%, first case and the last case. I enjoyed really good results in conventional Lotus. But in the Lotus Edge system, the Edge technology lead to the early expansion of distal frame. that may touch LVOT. Thus, in my early experience of edge system, I made a complete AV block, about 4 patients. Then I understand and I try to maintain the valve as high as possible from the start. Thus, I was able to reduce the complete AV block and PPM implantation. Plus, the third issue is leakage. If you meet the patients with high probability leakage, you have to consider Lotus. In Reprise 3 trial, they compared Lotus versus core valve in 900 patients. The only significant difference is leakage. In core valve and Lotus, from baseline, discharge, 6 months, 1-2 years, non-trace mild regurgitation is greater in Lotus system. Severe regurgitation was not there. That is a very important virtue of Lotus. Then I will show the several shots taken today. Andrew, please. Okay, we puncture the common femoral artery under the guidance of fluoroscope, plus, here, plus. Then I performed coronary angio, it's good, plus. You don't have to do PCI before TAVI, plus. Then I shot the root arterography. The expected angle was not correct, so we have to adjust best angle to make the 3 cusps at a single plane, plus. We introduced stiff wire. On the guidance of stiff wire, we introduced the sheath of Lotus, the biggest sheath among 3 companies available in South Korea, plus. So I introduced the straight wire into LV. Not easy, even though valve area is 0.9, it takes a little time. Okay, then I introduced the catheter plus curved wire plus, then pigtail. So as you can see, we 한 번 더 할까? Flushing. We did double tracing, pressure. LV pressure is maximum 190. 할 필요 없다니까. 그냥 on 해. Okay. Out pressure is about 140, so there is a significant pressure gradient. Then we are going to do procedure real time.
Dr. Kim, Dr. Kim, the presentation is too straightforward. Let's have a discussion about your cases with panelists. Actually, we have a panelist, 장기욱, 최영진, 홍구루, 권성우, 이중희, 임영효, 조정근, 손장원. Okay, your case is quite excellent and some educational. Any comment over or the question about his cases?
LA 없애고 카우델 뭐라고? 15, 10, AP 10.
If there is no question, I have some question about it. Actually, this patient is a 85 years male patient. Is a really good candidate for that. And you present the procedure itself and the disease itself. But we take care of the patient all about the beyond the valve and heart. One of the findings is that the patient renal function, EGFR is the 34, is the decreased the renal function. So I'd like to ask you the TAVI procedure with the lesser use of the contrast. Actually, in this time, the peripheral angio and the coronary angio and the aortogram, it makes the use of the contrast dye. Maybe even though you perform the successfully lotus state valve employment, there might be the possibility of the decreased the renal function.
Yeah, that is a point that we always meet. Mildly impaired renal function and procedure based on contrast dye. I have many experience of maintenance of renal function, even though such kind of procedure after sufficient amount of dye injection. Because in case of TAVI, it's a little bit different from coronary, the simple coronary intervention. After TAVI, the general systemic perfusion is really improved. So in my experience, even though we introduced a substantial amount of dye, I did experience worsening of renal function because of improvement of systemic perfusion. In any way, we have to care about limitation of usage of contrast dye considering even mildly impaired renal function.
So far,
Good point.
how many amount of the contrast did you use so far?
I don't know. 얼마나 했죠 우리가?
About 40 milliliters, I think.
Okay. And the second one is actually the
자, 비교 할게.
25% of the permanent pacemaker rate a little bit higher, even though it's at the lotus edge. What is your explanation of a relative higher rate of the permanent pacemaker rate in the lotus edge?
In conventional lotus, the valve expands simultaneously, upside and downside. But in lotus edges, depth guard technology, it just let the early expansion of distal frame. That is a kind of early strong touch between expanding frame to LVOT. Thus, the implantation technique should be different between conventional lotus versus edge system. Thus, I try to maintain the distal frame or distal sheath as high as possible from the start. I will show you in a little bit later.
Let me ask about
But,
your personal impression about the lotus edge versus the original lotus, because you have a lot of the experience of the lotus. What kind of the lotus do you more prefer? Even though the original one is at the out of market.
I advanced the system around the aortic artery. The most important thing is it is pre-shaped. Thus, you have to maintain the marker outside of curvature. As you can see, this is LL view. I widen the aortic artery, then let the marker outside, then I advance cautiously, maintain the wire.
Okay, actually,
It is pre-shaped, thus it is not difficult to advance.
experiencing a lotus valve is
The best angle.
not common. Please teach us as much as.
조정. Testing.
This patient has severe calcification at aortic arch. Lotus valve system is quite bigger diameter. Does lotus edge have possibility of lotus have a chance of damage of the aortic arch?
Yeah, higher chance. So you have to be very cautious. Testing. 노멀로 해볼까?
라이브를 보여주십시오. 패널리스트 얼굴 말고
자,
라이브.
you can see the sheath edge is about annulus level. Test. So don't push further. Just we start we start deployment.
Okay, I'll start deployment.
Deployment.
Deploy.
Okay.
Deploy. Deploy. Deploy.
Could you show us some hemodynamic during the deployment of the valve rather than the operate hand?
좌상기에 헤모다이내믹스 줘야지.
Deploy.
아니면 좌하기에 주든지.
Deploy.
박경택 좀 제대로 해봐. 내가 이거까지 신경
Okay,
써야
looks
돼.
good.
자, now you can see the distal frame is just around the annulus. 저장. Test. Okay. You can see.
That is,
Just
is
deploy.
that the original technique for the lotus valve?
Deploy.
No. It's edge specific. 야, 가만히 있어라. 내가 이야기 좀 영어 하는데 그냥 넘어가면 어떡해. 자, now the distal post is annulus level. The first sheath distal annulus level. Second, distal frame of valve annulus level. Third, distal post annulus level. That is very important. Test. You can see distal post corresponds to annulus. Okay? Then I slowly deploy to
Okay.
avoid deep dive or push out, pop out. Deploy,
Deploy.
deploy,
Deploy.
stop. Deploy,
Deploy.
test. Still, distal post is annulus level. Deploy, stop. Deploy.
Deploy.
NC calcification is very heavy, so it inhibits expansion of post left side. Deploy,
Deploy.
deploy,
Deploy.
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 Show us the hemodynamics.
자, 포스트를 싱글 플레인 해볼까?
이 얼굴 화면 큰 거 필요 없습니다. 플로로스코프하고 헤모다이나믹을 좀 보여주세요.
오케이. 테스트 준비? 테스트? Okay, I think the position is a little bit high. How about?
Looks good. It's excellent. It's
Little bit high.
very educational, very good cases for the TAVI
Okay,
session.
just we are going to recapture to make the system a little bit lower. Recapture.
Recapture.
Slowly, slowly.
Slowly.
Is there any chance of the shortening of the valve when you deploy the valve?
Stop. Okay. A little bit. Recapture.
Recapture.
Okay, stop.
And this time you
To be-
slightly advanced.
No, recapture.
No. Recapture. Just test it. Okay. I try once again deployment from this level, a little bit lower than before. Deploy,
Deploy.
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 And now it's quite interesting the maintenance of the stable the hemodynamics during the valve deployment.
Yeah. That is very good virtue for this system. Early valve function, stable hemodynamics. Plus deploy.
Deploy.
However, on
Deploy.
EKG monitoring,
Deploy.
the QRS is widening,
Deploy.
so maybe some damage to the
Yeah,
conduction
very
system.
frequent. Very frequent. Deploy. Deploy.
Deploy.
Deploy.
패널 뷰 말고 플로로스코피를 보여주세요.
So now this the post corresponds to annulus level. Until now, it is good. Deploy.
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 Now we can see the waist. So I push the system a little bit forward, gently. That is termed as a centralization. Previously, it is called as layover, but now centralization, emphasizing gentle, mild forward. Okay. Deploy,
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 deploy.
deploy.
Testing. Now we can see the distal post is a little bit rising. Final destination is just midpoint of sinus valsalva. Deploy. Okay, now we are going to check the twisting. Okay, 자, LAO. A little bit more. Cranial. Stop. A little bit further. LAO. Good. A little bit. Okay. There is no twisting. Okay, at this angle, we can continue the deployment procedure. Deploy,
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 deploy.
deploy.
Okay, previous angle. We are going to return to previous angle because this angle, the pigtail is overlapped.
Dr. Kim, I would like to say that in this point, it's important for the first assistant to feel any resistance in the deployment.
약간 cranial.
What is the teaching point
Caudal.
for the deploying the
Caudal.
lotus valve at this time?
In the aspect of the first assistant, I think that it should be done very slowly because there is tension within the valve that should be released very slowly. So the first assistant should wait until there is no tension within the rotation and then wait for a click.
No,
which
what
will
I
be
mean in
meet
the
in a couple
fluoroscopic
minutes, I think.
finding is what is the point
Test.
during the release of the valve?
Fluoroscopically, you have to keep an eye on the movement of distal post. Now the distal post is already midline of sinus valsalva. So I think it's a little bit high, but further upward movement would be minimal. So I can maintain the distal frame just below annulus. Thus, I try to advance more because I think the position is very perfect. The important thing is this is very complicated mechanical system. So deployment process should be very slow, because we need time of force delivery from the hand to the distal edge of the lotus system. 어떻게 지금 뭐 해도 되겠지, 그지? 조금 더
Yes.
advance 해볼까요?
Deploy.
Deploy. So please see the two mark close to each other. Uppermost post and descending buckle. Finally, they contact each other. That is a result of locking process. 좀 높지 않을까? 괜찮을까? 자, 테스트 한번 해볼까요? 테스트? 뭐 괜찮네. Okay. Just once again, slow deployment. Deploy. How about the feeling of tension?
I am feeling some resistance. I think we need to
Slow
wait
down?
yes.
Okay, slow down.
But we can see that the two posts are very adjacent to each other right now.
There are contact between buckle and post, at least on the two posts right side. How about left? 1 millimeter apart. Okay. Can you see the contact of buckle and post on the two right side?
Actually, you are the only one expert about the lotus valve. So please keep
Okay,
going and teach us.
Okay.
You know, in the COVID area,
Slowly,
there is
once
no
again.
the
How about tension?
I think I'll have a click in the next rotation.
Click. Okay.
So I have to wait for a minute.
Wait a minute.
Yes.
Anyhow, the impression is that in some patient with during the valve is sometimes suddenly the hemodynamic state was the change and the deteriorate. At the time, the operators have some they hesitate to deploy the valve fast, but it is too much time to deploy the valve. Electively, with the maintenance of the hemodynamic is the excellent.
How about now?
Deploy a little bit more. Yes, next time I'm going to feel a click.
Okay. Just go.
I'll go to the click right now. Now, I just felt the click. I will go more. To the end, yes.
Then. Okay, that's good. Just cine. Okay, this is final position.
Okay.
There is no change anymore. Then we are going to move on to the release step.
Let me ask one more. Is there any chance of the shortening of the valve, particularly in the low part of when you release of the valve?
No,
Okay.
just fixed. There's no further change.
Is there
If the locking process was complete.
okay? Is there no chance of the
If the
shortening?
locking
I
was
think the
failed-
position is quite good.
If the locking was failed, when we do a release, the post flipped. Then we have to remove a whole system. Thus, locking is very important. Should be very slow to give time for delivery of force from handle to the distal part of system. Okay,
Now I will go to the next step.
Release?
Okay. Yes, release.
okay, release. First half release, move the sheathing aids. It's a fine thread made of metal. Then flip motion 없지?
No,
Okay, good. 자, the release second stage.
this is the second stage.
You can
All
see
released.
the movement of capture, sheathing aid. Okay, 수정하고요. Then we are going to remove the delivery system very cautiously
Okay.
because now still there is a sheathing aid touch the valve frame. Thus, I just rhythmically, gently withdraw the delivery system. Maintain wire.
Okay.
What about the right side one? Is fully detached?
Yeah, the system is fully detached.
Okay.
Sheathing aid is just contacting the sheath.
Okay, good.
Okay,
Good, good.
저장하고요. 자, 뽑을게요. 와이어 스테이 하고요. 오케이, 캡처를 해야 되네.
캡처하겠습니다.
좀 바깥에서.
Why don't you pull back over the whole system? It looks like there is a chance of the scratch
Yeah, we are going to recapture.
within the caster.
Capture.
Okay, good, good.
Okay, just 들어갈게요. 와이어 스테이.
Wire stay.
Is this procedure is a local anesthesia, not general?
We can do, but
Currently,
오늘
it's not in general anesthesia. It's
yeah,
done
local
MAC.
sedation, MAC. Pigtail. Okay. So we are going to change the stiff wire into pigtail because in Lotus we don't do post dilatation.
Right.
Post dilatation may just tear the very complicated component of valve locking system. Thus, it is principally it is not recommended to do post dilatation. So pre-deal would be allowed.
Dr. Kim, I have two questions. How about the possibility of pop-out during implantation compared to Evolut R? And then how about the
What?
the chance of pop-out
the risk of
during
pop-out.
implantation?
Pop off.
Out compared to Evolut.
It's less than Evolut.
Especially in LVOT, the basal septal hypertrophy and severe calcified aortic stenosis patient.
My experience is there is some instance of pop off, but the frequency is very low because the valve function only. Thus, outforcing flow pressure is not so high compared with Evolut. So I retrieved impacted 좀 AP 해줄까? Pigtail catheter. Okay. I retrieved the out pigtail catheter. Then we are going to do double tracing.
LVOT에서 많이 나오는 원래. 근데 아까는
내가 이게 이렇게.
더
자,
들어가야 될 것 같은데.
제로 맞출게요. 갑니다.
아, 블러드 흘리는데 이쪽은 너무 근접합니다. 랩 사이드.
All lotus valve procedure do not require external pacing during the procedure.
Do not require.
Even though high blood pressure.
Yeah. 혈압 좀 낮춰볼까요? Rapid pacing is not required without pre-ballooning. 자, 앵글 좀 맞추고 동준만. 에코가 지금 없지. 자, pressure gradient disappeared, and we can see the several points of pressure. The systolic pressure is about 150, 155. Dichrotic notch is about 95. Diastolic pressure is about 60. LVEDP is about 25, 26. 자, 불러볼게요. 100. 지금 혈압 좀 떨어지네. Okay. Wait a little bit to the change for the blood pressure changes. We are going to calculate the AL index.
Personally, I think is that the AL index is a good indicator for the predicting the severity of the paravalvular leakage or not. Personally, I more prefer the directory imaging. For example, the transthoracic echo and or the transesophageal echo in the directory. That is the more important than the indirect message from the hemodynamics.
We check at least 3, hemodynamic and echo and angio. So we are going to present you.
Can we have the echocardiography on the screen, please? It's because this patient is not on general anesthesia. We cannot do a TEE, and we are performing a TT right now.
Patient has very poor echo window, and anyway, this is parasternal long axis, and next is parasternal short axis view, magnification view. There is no significant paravalvular leakage.
자, 혈압 보자. 보이지도 않는 TTE 아무 의미 없네.
Only probable central AR.
오케이, 혈압 보면은 systolic blood pressure is about 115, 115, dichrotic 65, 68, diastolic 50, LVEDP 20. 오케이, 프레셔 내리고, 디지트 내리고. 오케이, 디지트 보여주나? 우리한테 내려줘야지. 자, AR index is about 26. New AR index is more than 5. Let me introduce two kinds of AR index. Slide, please. As you can see, the slide, there's traditional AR index, that is B over A. When we made the ROC curve for this traditional index, the predictability is just 60%. So we try to make a new, more effective AR index that is simple, reproducible, to predict PBL after TAVI. The answer was C over D. C over D. We used dichrotic notch. So new AR index 4 is very good result. Less than 3 is not sufficient. Cutoff value is 3.3. If it is more than 3.3, there is no chance of significant regurgitation. In this case, just 5. That's very good. Okay, we are going to show you the final angiography. 노멀 미디엄으로 할까? 네. 이렇게 쓰네.
Looks good.
Actually, no regurgitation. 또 left 쪽, 약간 left 쪽.
Dr. Kim is quite excellent and the educational, and nowadays the live demonstration of the lotus valve in Korea is very difficult, and your case is really nice.
EKG, hemodynamic.
Dr. Kim,
슬라이드 대신에
I lately two questions.
좌상기, 좌하기 바꿔야지.
The first one
Yes,
is
please.
why did you support by echocardiography in during stand positioning? The second is first time you mentioned the distal positioning is very
사람 좀
important
바꾸라는 게 좌하기.
for preventing pacemaker implantation. But firstly, you stand side position is slightly distally, proximally. After then, recapturing you slightly advance the distal position. Why at first you slightly distally positioning is that's one simple approach. Why did you do two proximally position
Recapture?
after then recapturing the distal advance?
Okay, at the first try, I expect that would be a good final position, but during a procedure, I expect the position was too high. Thus, I just let the valve a little bit lower, but without recapturing, it is impossible to get the system lower position. That's the reason why we recapture and make the profile shallower and then we advance, make them to be lower, then restart deployment procedure.
In my
The
opinion,
valve is expanded, it is fixed. We cannot move the valve, so we have to recapture when we try to move the valve position. What is the first question?
if you support the transesophageal echocardiography,
Echo,
that
okay.
time you will
In my
go-
more than 300 cases, I try to focus on the angio, not distracted by echo recommendation, interpretation, because in the early phase, I don't feel any benefit, advice, or guide from the echo during procedure. Because I just focus on angio finding, so I don't use echo during procedure.
stent positioning is very important. Therefore, echo support is useful.
No, you can do by angio.
I see.
Okay.
If you perform a MAC, TTE is very poor in imaging, so you cannot get any information from poor quality of image of TTE.
Okay.
In TE, it may be possible.